Um, we've talked a lot about recruitment, and I think that's appropriate. A little bit less on retention. Of course, we talk about uh, salaries and benefits and stability and mission. But I wonder again if, as we come toward the end of this panel, if you have any concrete steps you've taken in your departments that you particularly want to elevate for the audience as things that you've done or that you've seen others do that you think, yes, we all know those are the things that keep people, but I just saw the best example of that and I want people to know about it. Any of you have some examples that you'd like to share?
Yeah, let me say this, that, although we are talking a lot about, entire public health infrastructure, but there are rural health agencies, places like Iowa, they don't have anything really. I mean, they have maybe a couple of staff who are, and this article has not, this article has not included those very rural health agencies. So we have to also keep in mind how they are going to meet these challenges, ongoing challenges, and the challenges of future too. So that's another dimension that we must not forget. Secondly, I think, we have missed out on the opportunity of branding and marketing our public health, especially in rural and local health agencies across this nation, because we don't have that kind of resource available. We don't have those kind of funding, and my colleagues have been talking about this $3.2 billion funding. It remains to be seen because we have 50 states and more than 3,000 local health agencies, how this funding is going to be utilized and for what's. I can tell you one thing here, that we are in Iowa, and we received, about $30 million for public health infrastructure, and out of that funding, 40% has to go to the local health agencies. Now, state has decided that they are not giving it to the local health agencies. Rather, they would create a regional infrastructure that we don't know what kind of regional infrastructure that is going to be like. So, we have to learn a lot, especially after this pandemic, and we have to reassess our way of doing work, how we can continue to engage our staff, marketing and messaging that I talked about, branding of public health, current landscape of politicization, how we are going to address that, navigating civil services structure. Some of my colleagues talked about that. Physical infrastructure. The other thing is that a lot of local health agencies, I don't know if you have seen, they have roof leaking. There is not, good infrastructure, physical infrastructure to work in. We were very lucky to have this very nice state-of-the-art building here a few years ago, before the pandemic. But, it's not just one health agency or two health agencies. We are talking about national health here. And we don't have any approach. We don't have any strategy at the moment. We are talking in bits and pieces. There is, our conversation is very limited, and, sometimes we get excited and then the excitement fizzles out. So I think we have to have a unified, cohesive approach to deal with governmental, to enhance the governmental public health infrastructure. And of course, unfortunately, we have to work in a system which is so much political.
Two things that I might just add to some examples. I think North Carolina did some great work on just making really great videos of this is some really cool stuff that we do, and as a reportment. And it also just as previously mentioned, brings joy to the workforce that's there, right? I think we go where we look, and I think sometimes we are really good at public health at talking about obesity rates and diabetes rates and how people are leaving. And I think we need to talk about resiliency factors, and we need to think about the joy of the work. And I think we need to do that in workforce too. I think that we need to bring up the joy and the incredibly profound amazing opportunity that it is to work within public health. I mean, it has been the greatest opportunity of my lifetime that I wouldn't trade for anything. And I think we need to share those stories more. So I think there are a bunch of videos coming out and other recruitment tools. The second thing, you know, something that we did in Alaska, and we used our state dollar, our infrastructure dollars to do this, was to reflect, connect into vision. And with that, you know, we spent money to bring like our public health nurses who work across this gigantic state that's bigger than Texas, California, and Montana combined, to come to our public health summit and to come to a 2-day leadership thing. A lot of them haven't had the travel funds in 10 years to be able to come together. And so instead of feeling like you're on your own, as Pramod said, like me and 2 other people in this community, being able to like reflect and connect with other public health leaders to be able to work in that space. Everyone from our labs to our, you know, medical examiners to our epidemiologists, understanding each other's worlds and bringing that together. And then now we have regular meetings that are done via Zoom, just because of how far apart we are on a regular basis, with a once-a-year commitment to kind of bringing people back together again. So there's a connection, but there's a comment by Jai Hyatt: the opposite of addiction is not sobriety, it's connection. And I oftentimes think that the opposite of many of our problems is connection. And so I think the more that we can build connection within our public health workforce with each other, as well as with our partners, the more that we can provide resiliency and the more we can look at where we want to go, not just the pitfalls along the road.
Yeah, that's really great. The last thing I'll add is, you know, this Health Affairs article really lifted up the less than 35-year-olds and those under 5 years in the public health workforce. So in our call to action, we have a focal area that we can really target, particularly knowing the 80% projection with that group for 2025. And so thinking about, you know, just the mindset, the energy, the creativity that that generation brings to the work. As leaders, we have the opportunity to somewhat block and tackle. Some of it sometimes needs to be refined and supported because it is in this larger system. But what are some things we can move out of the way that allow for them to really thrive? I'm sure there's more of the understanding of what's needed for the community. How can we really make sure the flexibility, the teleworking opportunity, the opportunity to leave the office and go out into the community to engage can be offered to that group? And when I think about the amazing senior leaders that I was so honored to be surrounded by at the agency, who were just committed and engaged, that institutional knowledge, we can think of ways to have that pour into our less than 35-year-olds, and you know, they are less than 5-year-olds, 5 years. I'm sure there are different mechanisms, but you know, really keeping that in the forefront as a driver for ways to improve and respond to this call to action can be helpful, knowing the energy that that age group brings to public health.
I'm glad you highlighted that. We tend to think of recruitment at the beginning and retention at the end, but part of what the study shows is we need to think about retention the moment people are there. That's a very high risk group for leaving. And obviously the retention strategies are very different for the under 35 who's been there for a handful of years and someone who has a life of knowledge and experience that you want to retain. You need them both for different reasons, but they're not going to respond to the exact same motivations and ideas. Well.